Good evening, everyone. Welcome you all to Oncology Classroom. In this month of August, we are going to have a couple of very exciting talks on pediatric oncology. And to begin this month, the first talk will be on role of molecular imaging in pediatric malignancy. And this class will be taken by Dr. Abhishek Khare, who is a Senior Consultant Radiation Safety Officer and Head of the Department of Nuclear Medicine Division at Platinum Imaging Center, New Delhi. Welcome, Dr. Abhishek, to this evening session of Oncology Classroom. May I now request you to take over the session and start your presentation. Thank you for being with us.
Unique with the age group, which are seen in those particular age group, while adult malignancies have a different behavior and different presentation. So, in the introduction, I think can I minimize this? Okay. So, cancers in children and adolescents differ from those that develop in adults. The predominant type of pediatric cancers are leukemia, brain and CNS tumors, bone and soft tissue sarcomas and lymphomas. Some of the cancers that develop in children are rarely seen in older individuals, notably those cancers which arise from the embryonic cells and originate in the developing tissues and organ systems. Now, molecular imaging with PET-CT, because basically the imaging modality is PET-CT, provides a non-invasive, semi-quantitative, physiologic method of detecting metabolically active malignant processes in a single hybrid scan. So briefly, we'll discuss on the principles of PET imaging, how imaging is done. Then we will go on to the individual type of cancers. Then in a subsection in the last, we will discuss on the role of MIBG imaging in neuroblastoma. Am I audible to everybody?
Yes, your voice is clear.
Okay. So the workhorse tracer in molecular imaging, cancer imaging in oncology is F18 fluorodeoxyglucose, which we say as F18 FDG. FDG PET scan, or simply a PET scan, is the commonly used term in day-to-day working. And so when you say a PET scan, it means a FDG PET scan. It means a FDG PET CT scan. And FDG is basically a glucose analog. When we give FDG, it is administered intravenously and is transported into the cells by glucose transporter proteins, just as unlabeled deoxyglucose in the body. Malignant tumors express more specific transporter proteins like GLUT1 and GLUT3 with a greater affinity for glucose than those expressed by normal cells, and therefore malignant tumors have a increased glucose flow and retention in the cancer cells. So basically, this is the principle that malignant tumors would concentrate this FDG compared to the normal cells, because we all know about the Warburg cycle. Malignant cells, they undergo anaerobic cycles and they don't go into the oxidative phosphorylation like in normal cells. Now, here is a diagrammatic description where we are seeing the basic principle of PET. Now, I just wanted to emphasize, when we inject FDG into the blood, which is actually an analog of glucose, what happens? Now, we have normal glucose as well as FDG. Now, this normal glucose in the bloodstream goes into the cells, is transported by the transmembrane receptors, is phosphorylated by hexokinase. It is converted into glucose 6-phosphate and then undergoes glycolysis. What happens with FDG? This is 18 fluorodeoxyglucose. This, when it goes into the cells by the transmembrane proteins, it is again phosphorylated similarly to glucose. It becomes FDG 6-phosphate. But from here the cycle stops. This is basically the key point in PET imaging. That means FDG, which is transported into the cell and phosphorylated in parallel with glucose, which is done by hexokinase, is actually metabolically trapped into the cells, and therefore these cells have increased uptake and retention in such tissues. What happens? So when we have this FDG6 phosphate, which is radioactive glucose in the malignant cells, this gives a sharp contrast with the normal cells. And this is actually a positron emitter. So it emits a positron, which is actually an antiparticle. There, inside the cell, it goes into a phenomenon known as annihilation. It annihilates with an electron to form two gamma rays which are coincidence rays at 180 degrees. These travel to the detectors and are catched by the detectors, and therefore we get a map of where is the malignant cells or malignant tumor or the malignant processes in the body. That is how we map the malignant cells in the body, because of this unique phenomena of this FDG6 phosphate not undergoing the glycolysis. Meanwhile, if anybody has any doubt or any questions, they can actually give a question or a ping in between. That won't derail my train of thoughts. Something about the tumor biology and FDG uptake. FDG has been applied to tumor growing and prognostication. As a general principle, I'm saying high-grade aggressive tumors have a higher FDG uptake than low-grade tumors. Now, I want to talk about a unique pitfall, because this pitfall is important, and I know most of my oncology colleagues know this pitfall. Just to emphasize on this pitfall, FDG is not a tumor-specific agent. Unlike PSMA or unlike MIBG, this is not a tumor-specific agent. And its increased accumulation may be seen in variety of benign conditions, including concurrent infection, inflammatory conditions like tuberculosis or pneumonitis, physiological process. For example, in an ovulating ovary, you can see an uptake. Post GCSF therapy, a patient of lymphoma or myeloma who's had a granulocyte CSF therapy can demonstrate increased uptake. Muscle trauma, muscle strain, chemo and radiation associated flare response, early post-op or post-biopsy changes also. So there is a plethora of conditions which can actually cause an increased FDG uptake. Now, how do we differentiate between these benign conditions to a certain degree? I will not say that we differentiate it absolutely, but to a certain degree, we are able to differentiate when we combine the PET-CT, which is the norm, and it makes us easy to interpret these benign conditions. For example, in the lung findings, you can see granular opacities and you can see FDG uptake post-chemotherapy. You understand it's because of post-chemo pneumonitis. So these are some things which we need to know. And we also need to know that FDG is not a tumor-specific agent. There is no key and lock binding mechanism in FDG. Now, going on to the standard protocol. Now, the standard protocol for pediatrics is the same as for adults. The patient preparation, fasting is required overnight, or in case of children, at least for 6 hours. No exercise previous to the exam. So basically, the thing is that children should not run or should not be more active physically. Once we give the injection, we need to hydrate the patient. For this, basically, we are already giving the oral contrast, so the hydration is done with that. Mild sedation may be required in children who are of lesser age, maybe 6 or 8 or 3 or 4 years of age. Those patients may require sedation because they may not be able to lie still on the scan. Blood glucose is the same, should not exceed 200 milligram per deciliter. Now, blood glucose is not an issue in pediatric population. Basically, pediatric diabetes and all those things are not very common. So we don't see this issue of blood glucose, which we see with adults. This is not very common in pediatrics. So if the child is fasting, we don't see this problem of blood glucose. Now, why blood glucose? Once again, because we are giving a radioactive form of glucose, which competes with the normal glucose. So we don't want the normal glucose to be high, or the tumor cells which are going anaerobic metabolism, the Warburg cycle. We don't want them to take normal glucose. We want the tumor to take only radioactive glucose. So we want the blood glucose to be 200. Generally in my institution, I have seen, we generally see blood glucose level of 80 to 120. So not a concern here. Patient imaging, generally we scan the patient. This is actually a slide which is a universal slide, but we take the scan around 45 minutes to 1 hour. A delayed scan may be required. In that case, we take the delayed scan at 1 hour to 1.5 hours after the initial scan. Reconstruction is 3-dimensional. We have a 3-dimensional image. Timing of PET scan is something that I think most of the oncologists or referring physicians know, that we need to have at least 6 to 8 weeks after treatment of chemoimmunotherapy. If pre-treatment scans are required, so the post-treatment should be performed within 2 weeks of therapy. This is for early response assessment if the oncologist wants to know early response in case of chemotherapy. Dose is basically, FDG dose is basically 0.3, basically 0.2, but it's 0.1 to 0.3 millicurie per kg. Now, for the general population, I mean, what I would like to say is that the minimum dose for pediatric age is 1 millicurie. 1 millicurie is the minimum dose, whatever is the age, we don't give less than 1. But then if the child is 20, we can give 4 millicurie, 3 millicurie, according to it, we individualize the dose to reduce the radiation and nothing else. Okay, acquisition is from the base of skull to mid-thigh, unless there are areas of concern that there is a brain tumor or there is some metastasis like a neuroblastoma, which can have marrow metastasis even in the calvaria. So the standard is base of skull to the mid-thigh. Now, this is just a demonstration of PET CT. We all know this is the PET CT which I am using. This is G Discovery IQ PET CT. Now, I have a very simplified view where we have, just to people or residents who want to understand that how a PET CT machine is. Basically, this is the scanner table and this is the PET gantry. This is the CT gantry. So basically, we have 2 machines or 2 gantries in a single scanner. So that is a PET CT scanner. Now, PET CT is a fusion of metabolic and anatomic information acquired almost simultaneously that lets us see the whole body and the disease in a way that is diagnostically powerful. What type of views do we have? Now, this is the CT transmission scan. Now, this is the attenuation corrected PET scan, PET CT fusion scan, and this is the NAC scan. Now, just for the information, I want to tell what is the difference between the NAC scan and the attenuation corrected scan. Now, this scan is not attenuation corrected. You can see a lot of uptake in the skin. The skin creases are very prominently seen in the NAC images. But when you see the attenuation corrected, this is not prominently seen. So what happens, the rays which are coming from the periphery, they don't have an attenuation. They're not attenuated by the tissues. But for example, if a cancer is there in the vertebra, in the liver, that has the ray which is coming to the scanner has an attenuation from the normal liver. It may have an attenuation from the abdominal muscles or the vertebra or the bone. So we will not be able to see it. So CT basically used for 2 purposes in PET CT. One is for attenuation correction. That means we should actually be able to see from where the lesion is there. If it is deep, the scanner automatically corrects it for that soft tissue so that we are able to see from where it is coming. This is actually a normal scan. And second is for localization. So attenuation corrected PET scan, PET image is fused with the CT image to get the PET CT fusion scan. Where is NAC images required? It may be required in melanoma, where there is a skin cancer, where there is cutaneous metastasis. In those cases, we may require a NAC image, and we regularly acquire the NAC image is also there, and we see it in those cases. Image views, as everybody is aware, we get in the coronal plane, in the sagittal plane. That this is just to emphasize that we are doing a three-dimensional fused images. Now, this is the transaxial plane, which is most commonly used for our diagnosis or diagnostic purposes. One important image is the fusion MIP image. This is the fusion MIP image, which we get a revolving image, and that is the maximum intensity projection image in PET. Now that gives us a very good idea of where is the abnormal lesions or abnormal radioactivity located in the whole body. In this is a normal image, so we are seeing activity. We are not seeing the brain, but we are seeing the myocardium, we are seeing the kidneys, we are seeing the bladder. So this is a normal image. So once you get used to this, you will be able to make out on the MIP image, okay, this is a focus which looks abnormal to me. But once again, with PET, we have to remember, PET, when I say PET, I say FDG PET CT. So we have to remember that there may still be concurrent inflammatory infective findings, which may appear hot or dark here, which may not be related to cancer. That is something we have to fuse with the CT and see. So just to confirm, I am audible to everybody. Hello.
Hello.
I am audible to
everybody?
everybody.
Yeah. Everything is audible.
Okay, thank you. So now physiological distribution in children. This is very important. Why? Physiological distribution is in adults also. Why we want to emphasize on children? Now, physiological distribution in the brain, extraocular muscles, vocal cords, liver, myocardium, bone marrow to a certain extent, and the GIT, genital tract, as well as diaphragmatic activity may be is normal. Diaphragmatic activity may be seen in children who are crying or have a strenuous breathing during the uptake period. When I say uptake period, it means time during the injection and the scanning. Similarly, there can be more FDG uptake in areas with lymphoid tissues like adenoids, tonsils, thymus, and skeletal growth centers, the epiphyses, particularly the long bone epiphyses. One problematic area in children is brown fat FDG uptake. This is somewhere where we see a non-shivering thermogenesis. High mitochondria in the brown fat, they give a very high uptake. They are very metabolically active. So thermogenic adipose tissues, the brown fat FDG uptake, which is often, now how do we make it out in PET scan? That is important. Even I can make it out. I know experienced oncologists, radiation oncologists, other people can also make it out. It's basically, it is often bilateral and symmetric and is located in distinct locations, particularly involving the neck, cervical region, supraclavicular, mediastinal, paraspinal, perinephric, and paraadrenal regions. Where does this pose a challenge to us? It poses a challenge in case of lymphomas, where you have nodes also in the cervical region and you also have this brown fat. So the thing is that in the West, they have a very nice, a way of putting these patients into a scan. They will either give diazepam, or they will either heat the room, or they will schedule it in such a way so that the brown fat uptake is minimal. The brown fat uptake is more in the cold weather. It is more in the children, and it is more when the children is basically shivering or he's in those cases. So brown fat uptake can be minimized by use of diazepam. It can be minimized by propranolol. There are a number of ways to minimize it, but practically we are not doing any of these. But what we asked the relative, once we give the injection, we ask the relative to sit there with the child, so the child doesn't move or cry or anything else. We also give a warm blanket so that the brown fat uptake is minimized. Still, when they go into the scanner temperature is around 20 degrees, whether it is winter or summer or any other weather. So child still shivers, and they still have this brown fat FDG uptake, which is a little problematic in these areas. But with the PET CT, we are still able to make out where is the anatomical node and where is the uptake. Just to see the physiological distribution of FDG, lot of uptake in the brain, vocal cords. This is the thymus, very commonly seen in children, not in adults, and the urinary bladder. Some degree of uptake in the muscles and the liver and the hepatobiliary system. Once again, we have high uptake in the gray matter. Now, this in children is very common. Physiological uptake in the Waldeyers ring. The Waldeyers ring consists of 4 tonsillar structures: the pharyngeal, tubal, palatine, and lingual tonsils, as well as a small collection of lymphatic tissues dispersed throughout the mucosal lining of the pharynx, what we call as the MALT. So this is common in children. Now, for example, I get a case of lymphoma and I really need to know if the tonsillar involvement is there or nasopharyngeal involvement is there. I would really have to look into asymmetry, frankly, because normally there can be symmetric and high uptake in the Waldeyers ring. So I have to really look into asymmetry of uptake to say that these are involved. So this is a gray area which we have to accept. This is the uptake in vocal cord. Now we also see the uptake in the physis, the growing end of the bones, which is very commonly seen. And this is the brown fat. Now this looks very, very dark. When we were residents, we used to think that this is something abnormal. And we used to think that this is probably the area of cancer. But this is not the area of cancer. This is the area of brown fat, which we need to understand. Cervical, supraclavicular, much into axillary area, into the mediastinum. Very typically, you're seeing in the paravertebral, paraspinal region. Very symmetrical uptake. Very symmetrical uptake, both sides. You can make it out. This is brown fat. Brown fat, how do we make it out? When we see in CT, there is nothing. In the CT, is just fat. And when we see in PET, there is high uptake. So that is brown fat. Now, after all this, we are coming on to the common indications in PET CT in children. Now, what are the main indications? The main indications are lymphoma, Hodgkin's and non-Hodgkin's, sarcoma, neuroblastoma. When I'm saying PET CT, the MIBG negative cases is what I'm saying. And CNS tumors. We don't get a lot of many cases because I'm working in a center, but I believe hospitals get much more cases than we get. Less frequent is germ cell tumors, hepatoblastoma, Wilms tumors, and malignancy of unknown primary. Now, we are coming on to specific cancers in children once we have finished on the general description. Imaging in lymphomas. Now, FDG PET CT is the standard imaging modality for FDG avid lymphomas. Now, what are the FDG avid lymphomas? We all know. Just to enumerate: Hodgkin's lymphoma, any type; DLBCL, follicular lymphoma, mantle cell lymphoma, anaplastic large T cell or natural killer T cell lymphomas. These are FDG avid entities. Non-FDG avid or low-grade lymphomas. These include chronic lymphocytic leukemia, small lymphocytic lymphoma, lymphoplasmacytic lymphoma, Waldeyers, microglobulinemia, mycosis fungoides, or marginal zone lymphomas. CT is the investigation of choice for non-avid lymphomas if you want to image. Now, marginal zone lymphomas with aggressive transformation. Just one point I want to make. Still, PET CT is the imaging of choice if there is if suspicion of aggressive transformation. Now, FDG PET CT is the modality of choice for staging, response assessment, and to guide response-based treatment decisions following initial chemotherapy. Numerous studies, a number of studies which have been done, have now shown that early metabolic response after 2 cycles of chemotherapy, what we call as the interim PET, correlate very well with the outcome, and the so-called post-2 cycles PET CT is now being used to predict response to therapy, guide radiotherapy decisions, as well as to stratify treatment. When I say stratified treatment, I think it's mostly in the trials and maybe not in general practice. Probably the oncologist can tell better than me here. In contrast to the metabolic response to therapy, Now, changes in tumor size alone, when I say alone, measured either by anatomical imaging, CT or MRI, may not be predictive of outcome or response. So that tumor may not shrink as well, may not shrink that much in size, but when you see a huge reduction, when you see a significant reduction in the FDG uptake, when you see a complete reduction in the FDG uptake, you are very well sure that this tumor is responding very much to the chemotherapy, which may not be seen just on anatomical imaging. Now we have both. When we do a PET CT, we have CT as well as PET, so we are able to decide on the response. Now, one important point which was previously, I think, not there, but after the Lugano classification, after the Lugano guidelines came, presence of bone marrow involvement by FDG PET obviates the need for bone marrow biopsy in Hodgkin's lymphoma and most DLBCL. Until unless there is a discordant pathology which is suspected by the clinician that no, even after a normal marrow uptake. Generally, when I give my reports, I generally write whether the marrow uptake appears normal, whether it appears discordant, or whether it appears diffuse, that is generally post chemotherapy. So generally, when in staging, I try to give to the clinician how is the marrow uptake. Though now a radiologist may still have a view that marrow is better seen on MRI, but I think that PET CT gives a very nice view of the marrow, and once it is very heterogeneous or focal, we are able to tell that marrow is involved. So this is after the Lugano guidelines. It can also identify diffuse external disease, which may not be seen by anatomical imaging, like CT. For example, diffuse involvement in the spleen liver. Now, I have seen few cases, or rather number of cases, where the spleen or the liver was involved, and the CT was totally normal. So diffuse involvement, of course, there's a focal involvement. You have a focal lesion on spleen or liver, we can tell by CT also. But when there's a diffuse involvement, we are able to tell very nicely on PET CT. Currently, FDG PET CT is a modality of choice for staging, interim and end of treatment response assessment, and follow-up of lymphoma patients. Now, a special point which I want to tell is that in refractory and relapsed HL and DLBCL, PET is prognostic when you give a salvage chemotherapy. So if you want to give a high-dose chemotherapy and you want to see a PET scan, how is the PET scan after the salvage chemotherapy? So PET is very much prognostic in those cases for a high-dose chemotherapy and an autologous stem cell transplantation. So these cases come to us, and the clinician wants to know how is the patient which actually failed or had a relapse with these HL or DLBCL, how is the patient doing with the salvage chemotherapy? Now, the response criteria as mentioned in Lugano is the Deauville's 5-point scale. Lugano has both CT, PET and other criteria. I'm not going to Lugano here, but I just want to tell on Deauville's 5-point scale, which I know most of us, every one of us is aware of. Deauville's 5-point scale is basically a scale which compares the uptake of a lesion to the background. So basically, a score 1 is given where there is no uptake. No uptake means no higher uptake than the background. A score 2 is given where it is more than the mediastinal blood pool. This is a visual scale we have to remember. The Deauville's 5-point scale is not based on the SUV. Now, all the oncologists or radiation oncologists or oncosurgeons, they must be used to the SUV. Now, this is actually a visual scale. But when I report, I also give the SUVs. But to be clear, that Deauville scale is a visual scale. This is less than the mediastinal blood pool. 3. Score 3 is more than the mediastinum but less than the liver. 4 is moderately more than the liver at any site. 5 is markedly more, means 2-3 times more than the liver at any site or any new site of disease, which is actually graded in some systems 5A and 5B. X is new areas of uptake unlikely to be related to lymphoma. For example, we may see a Hodgkin's disease which is only in the cervical area, and you just see on the interim scan that there is a inguinal node. Now this is more unlikely to be related to lymphoma. So X is something which is unlikely to lymphoma, or some uptake which is unlikely to relate to lymphoma. So Deauville's 5-point scale is what universally all over the world everybody is reporting on lymphomas. What is important is the interpretation of Deauville score. Now I think everybody is aware. Score 1 and 2, no doubt, is complete metabolic response. Score 3 is also CMR with standard treatment, but in response adaptive trials exploring de-escalation, score 3 may be deemed inadequate response to avoid under treatment. Now this is basically for trials, otherwise it is CMR. Interpretation of score 3 depends on timing of the assessment, clinical context and treatment. Score 4 and 5. Score 4 and 5, what is score 4 and 5? 4 means moderately more than the liver. 5 means markedly more than the liver. 4 and 5 with reduced uptake from baseline. Now we are comparing from the baseline. Is partial metabolic response PMR. At interim, now the clinician decides that he will have an interim scan in between the chemotherapy to see how is the response. This suggests a responding disease. 4 or 5, even it is 4 and 5, but there is a reduced uptake from the baseline. At end of treatment, this indicates a residual disease. So we have to see when is the scanning being done, at interim or end of treatment. Score 4 or 5 with no change of uptake. There's no change of uptake on the baseline means no metabolic response, or what we say as stable disease. NMR is not commonly used in our country. We say stable disease. Score 4 or 5 with an increased uptake from baseline or new lesions. There is a new lesion, new node or new lesion coming, is suggestive of progressive metabolic response, PMD. At interim end of treatment, basically either it is NMR or it is PMD. They indicate a treatment failure for chemotherapy. Now I'm giving some examples. There is an adolescent male, partial response at interim scan. Here you see this is basically the staging scan. You see you see lymph nodes on both sides of diaphragm. Here you see the lymph nodes there is a gross shrinking in the size as well as metabolic activity, but there are still some nodes. For example, there is a node here which is much more than liver. I would say this is a score 5, and we are seeing some nodes in the mediastinum of the axilla. So this is partial response. Now this is response to therapy, but not CMR at interim. So this is probably the clinician will continue the same chemotherapy to see a response at end of treatment, but at interim this is not a complete response. A 4-year-old female, primary small bowel and NHL, staging PET, we see a splenic and marrow involvement. Now you see the spleen is generally less than the liver. You see the spleen shining compared to the liver. The spleen is shining, is hot compared to the liver. So this is at staging. When this comes post GCSF, post stem cell, post other things, I can still think that the spleen is probably shining because of those factors. No. At staging, that means the splenic involvement is there. And when I see the spine, I can see there is inhomogeneous and increased uptake in the marrow. This is suggestive of splenic as well as marrow involvement in a primary. This was a jejunal lymphoma. So this upstages the disease. Many times we have seen the PET is upstaging the disease. Now, an adolescent female, a pelvic mass with a bony involvement seen in the left hemipelvis is an NHL. Post 6 cycles of chemotherapy, we see a complete response. Just see how beautifully we are seeing the staging and end of treatment. Beautifully, there's nothing. This patient actually initially went for some homeopathic or some other treatment, alternative treatment, and did not take the chemotherapy. ultimately the patient pain and other things increased, and then they took to chemotherapy and got on the scan done under a renowned oncologist. And then we see end of treatment, there is complete response. So just to show this image, staging and end of treatment, you see this huge mass in the hemipelvis involving the iliac blades, and when you see the end of treatment, it is completely gone with some telltale residual sequelae which are suggestive of residual sequelae and not really disease. Now lymphoma, after lymphoma I want to go into another common tumor in children, which is sarcoma. In children, osteosarcoma is common, followed by Ewing's and rhabdomyosarcoma. Accurate staging and identification of metastases are imperative in assessing long-term prognosis of these patients. Bone marrow and lung are common sites of metastasis diagnosis. A full body vertex to toes. Basically, for sarcoma, we do a vertex to toes. May not be required in other cases, but sarcoma, we do a vertex to toes is done for this purpose. So we do a whole body scan, vertex to toes. We want to see anything in the calvaria. We want to see anything in the distal tibia. We want to see all over the body. Conventional imaging modalities, CT, MRI, show a poor sensitivity for small nodal metastasis. Now, nodal metastasis is not very common, we know. Everybody knows in sarcoma. But when they are there, they have a grave prognosis. For detection of lymph node metastasis, on contrary, PET has proven to be promising imaging modality for detecting lymph node metastasis with better sensitivity than conventional imaging. The presence of lymph node metastasis impacts outcome and survival, which can be improved by intensification of therapy and irradiation of the affected region. Similarly, the presence of pulmonary metastasis is associated with poor survival and dedicated chest HRCT. Now, dedicated HRCT we are doing it as a protocol in all the patients as a part of PET-CT remains the imaging study of choice for detection of pulmonary metastasis. Now, most common sarcoma, osteosarcoma, is the most common primary bone tumor in the pediatric population. Occurs in the long bones of extremities. Primary tumor is typically located in the metaphysis of distal femur, proximal tibia or proximal humerus. The most common site of hematogenous spread is common in OS. Is the lung, followed by bone and bone marrow. Metastatic disease of same bone is also we are able to catch what we call as skip lesion. Skip lesion can be of two types. One is in the same bone, other in the juxta-articular bone. It's a feature of OS in the long bones and can be detected by FDG PET-CT. In rare cases, osseous metastasis can be disseminated also. Up to 20% of cases may have detectable metastasis at initial staging. The lung mets are often calcified. Now, this is a unique feature of OS, which I will show in the scan, in one of the imaging I have done, that the metastases are calcified. Generally, we see calcified nodules in the lung. We say it is sequelae of old inflammatory or infective etiology. But when it is osteosarcoma, of course, in the children we will not have those old etiologies. But when we see calcified metastasis in the lung, we are very sure it is because of osteosarcoma. And non-contrast CT of thorax is the imaging modality of choice to see these non-calcified, to see these calcified lesions. Now, a 70-year-old male came to us with osteosarcoma. You're seeing an osteosarcoma here in the left femur, and PET-CT reveals pulmonary metastasis at presentation. So basically, I have these images here. This is basically the primary tumor, very nicely seen. But what I want to show you is in the next slide. We are seeing basically calcified pulmonary metastasis and pleural involvement. Basically, pleural involvement, pleural thickening, and uptake is here. These are the calcified lesion in the lung. These are suggestive of calcified osteosarcoma metastasis. Very peculiar and particular. An adolescent male osteosarcoma of left distal tibia with skip lesions in the tibia and the navicular bone. As I told, that skip lesions may be there. You're seeing a skip lesion here. This is the osteosarcoma in the distal tibia. You see one skip lesion here. This is in the just superiorly to the main lesion. You have another lesion here. This is juxta-articular. This is below, this is in the, here you see this is in the navicular bone. So juxta articular skip lesions can also be caught. And also in these cases, we do a vertex to feet scan to see if there are such lesions. Ewing sarcoma. Ewing's affects primarily adolescents with a peak age at diagnosis between 10 to 20 years. The majority occur in long bones of the upper and lower extremities, followed by the pelvis, thorax, and spine. Now, although Ewing's tumors are more commonly arising from the bone, you can see Ewing's arising from the soft tissue primary tumors. We can also see them. Mostly initial evaluation of primary tumors is done by either CT or MRI. Mostly we get those cases which are already diagnosed. To be frank, we don't get a case where it is coming for us to diagnosis. It is already diagnosed case. FDG PET CT offers one single test to see skeletal metastasis, particularly marrow as well as pulmonary metastasis, very common in Ewing's. And FDG PET is also very useful in assessing response to surgery and chemoradiotherapy in Ewing's, which is a sensitive tumor to chemoradiotherapy. Now, this is a child. We are seeing response assessment to chemotherapy. Hypermetabolic destructive lesion involving the right iliac blade with large soft tissue component shows near complete resolution with residual post-treatment sequelae in the right iliac blade. So there's no evidence of metastatic disease in this case. What we are seeing in the staging, there was not much brown fat uptake when he comes post chemo. This is all brown fat uptake here. But the lesion, if you see this lesion, there are telltale sequelae. You are seeing some osteolytic lesion here, but you see compared to the staging, the lesion is grossly shrunk in size, metabolic activity, and there's no uptake. This is an interesting case, basically, which I did not follow up, basically, because I mean, it was lost to follow up rather. It's an 11-year-old boy. Now, this case had a node in the neck, and when they did a FNAC, they said that it's a metastasis of unknown primary origin. FNAC of cervical lymph nodes is suggestive of metastatic carcinoma. Now, carcinomas as such are not common in children. We know that. When we did the PET scan, we saw a metabolically active, large, heterogeneously enhancing soft tissue density mass lesion involving the right lateral and posterior wall of nasopharynx. Here, you can see this lesion, right lateral and posterior wall of nasopharynx, and multiple lymph nodes on the right side, right level 2, 3, and 5. I'll just show in another image. So this was the lesion in the nasopharynx, and then there were multiple lymph nodes. Now, we thought it can be a nasopharynx, though in literature, CA nasopharynx has been reportedly very rarely in this age group. He was a 11-year-old boy, but it didn't come for follow-up. And once again, difficult. You see this case, so much of brown fat uptake, all particular paraspinal, cervical, and supraclavicular region brown fat uptake. But fortunately, the area we were looking, that area was much clear. So we thought it may be a primary in the nasopharynx. There are few cases which are reported of a CA nasopharynx in children up to 11 years, 12 years, 13 years also, but unfortunately lots to follow up. So, but we were able to guide if it was really a carcinoma, it was not a Burkitt's lymphoma, or it was not a lymphoma, that this may be the primary. So to be frank, we don't know the final diagnosis. Very interesting case of an 18-year-old male, pericardial synovial sarcoma, post 4 cycles of chemotherapy for response. This child had breathlessness. He had then because of breathlessness, he evaluated, and then ultimately an echo was done, and then echo said that he has an ejection fraction of 30%. And 30%, and then the echo said there is some mass in the mediastinum. We saw that there is a FDG with mass in the mediastinum. Biopsy was done, came out to a pericardial synovial sarcoma. Post 4 cycles, we see a very good response, which is a partial response, PMR, suggestive of good response to chemotherapy. This was a pericardial synovial sarcoma. You can see here. Now, the problem is that this, what you see is the left ventricular uptake. Myocardial uptake in the left ventricle is the pumping section of the heart. So basically, since it is metabolically active, it will have this uptake. But what you see here is, this is the tumor actually. You see the huge tumor here, and you see that this is only the normal left ventricular uptake. So this is a very good response, and this was deemed as a PMR partial response at 4 cycles chemotherapy. Wilms tumor is the most common renal malignancy found in younger children. It is rarely encountered after the age of 5 years. Bilateral renal involvement is seen in 5% of cases. Now, radiography, sonography, CT, MRI are commonly used modalities for imaging. Now, studies have described the functional imaging with FDG because they concentrate FDG variably, but a definitive role of FDG PET-CT in the initial staging of tumor has not been established. Normal excretion of FDG through the kidney is also a limiting factor. FDG PET is found to be most useful in identifying active tumor in residual masses that persist after radiation, chemotherapy, or both, and for evaluating the effects of treatment on metastatic disease. So this is basically, I would say, PET is more for the disease response assessment rather than the primary tumor imaging. Just one important point I want to say, because this is more of CT and not of PET, that some particular features are there that differentiate between a neuroblastoma and a Wilms tumor. An stippled calcification is more likely neuroblastoma and less of Wilms tumor. Neuroblastoma displaces the kidney inferiorly. The Wilms tumor arises from the kidney. Neuroblastoma tends like a mass crossing the midline, encasing displacing vessels rather than infiltrating them. The tumor thrombus in the renal vein or IVC is predictive of Wilms tumors. A neuroblastoma presents as a conglomerated mass with calcification of paravertebral mass with intraspinal extension. So these are more of CT points than PET points. So Wilms tumor for primary, I would not say that we are the modality of choice. Now to the subsection, I don't think that I have much time. Dr. Mandal, how much time I have?
I think you can take another 10-15 minutes, no problem.
Okay. So MIBG in neuroblastoma, radio-labeled MIBG, two isotopes, I-131, I-123. MIBG stands for meta-iodobenzyl guanidine. Just to go through, I think everybody of you must be more aware than me that catecholamine producing tumors are characterized by catecholamine production, and three major types are there based on the cell of origin and the degree of differentiation from the parent neural crust cells. So these are parent neural crust cells. Undifferentiated cells produce neuroblastoma. When they differentiate chromophene cells, they produce a intraadrenal pheochromocytoma or an extraadrenal paraganglioma. Sympathetic ganglion cells produce a ganglioneuroma. Just to give a basic idea, neuroblastoma, ganglioneuroma, pheochromocytoma, or paraganglionoma. When we were residents, we have a lot of confusion in these terms. Which is what? So neuroblastoma is the most common extracellular solid malignancy affecting children between 20-30 months of age. Origin, neural crust cell origin in the sympathetic nervous system, which are precursors of adrenal medulla, the chromophene cells, and the sympathetic ganglia. Tumor is most frequently situated in the adrenal gland or anywhere else along the sympathetic nervous system chain. At diagnosis, there is a high risk of hematogenous metastasis. I have a table. I will not go deep into the table. Basically, this is a comparison because of time restraint. Neuroblastoma, pheochromocytoma, and ganglioneuroma. Age of diagnosis, presentation, most common site of metastasis, percentage of metastasis, and all these metabolically active metanephrines, HVA, VMA, and metanephrines, which are in which. So just to give an idea that neuroblastoma occurs less than 10 years, pheochromocytoma 30 to 40 years, ganglioneuroma, the mean age is 7 years. So I'm not going to detail because of lack of time. MIBG, meta-iodobenzyl guanidine, is a noradrenaline analog labeled with either 123 or 131. We don't have 123 in our country. We have 131 only. For imaging so we have both for imaging, and for therapeutic we have only one, that is I-131. We don't have I-123. MIBG uptake in neuroblastoma is usually high with high specificity in tumors with primary neural crust origin. I-131 MBG is valuable for staging, detecting metastatic disease, staging and determining patient response to chemotherapy. The sensitivity for detection of neuroblastoma is reported to be more than 90% and specificity about 95%. Most have high FDG for MIBG. However, now this is an important point which everybody in the clinical practice should know. Approximately 10% of tumors are MIBG negative. For bone marrow metastasis, the sensitivity is 60 to 70%. Now, whole body MIBG imaging is generally felt superior to FDG PET in evaluation of metastatic osseous disease and remains the imaging test of choice to determine the extent of disease for staging, evaluation of treatment response, or for determining prognosis. Now, those neuroblastoma cases which don't take MIBG, 18F FDG PET CT, the normal PET CT which I say is a useful adjunctive tool for imaging. Neuroblastomas may be characterized by an overexpression of somatostatin receptors, more precisely SSTR type 1 and 2, making gallium-68 DOTA a potentially useful tracer in molecular imaging of neuroblastomas. This is also nowadays being done. There are few small studies having a small number of patients where they say gallium DOTA TOC or DOTA TATE PET CT is having a superior sensitivity in comparison to I-123 MIBG. Larger patient cohorts are required to support this observation. Primarily, neuroblastoma lesion was better definable on DOTA than on MIBG. Is that what they say? Because of one thing is the superior resolution of a PET CT compared to the gamma imaging. Now, to see the physiological tracer uptake of MIBG, we see in the brown fat. This is the brown fat uptake. Brown fat has a lot of sympathetic ganglia, sympathetic innervation. So we have high uptake in the brown fat. Nasal mucosa, salivary gland, heart, liver, bowel, and renal bladder. This is the physiological uptake of MIBG. Now, normally adrenal glands as such are not seen, but faint uptake may be visualized 2 to 3 days after injection of 15% of patient when using I-131 MIBG. I-131 MIBG, the half-life is around 8 days. So don't think about 2 to 3 days is a big time. 2 to 3 days we can image the patient. We can image the patient even after 7 days. Normal adrenal glands can be visualized up to, this is not like FDG where the half-life is only 2 hours. We have a half-life of 8 days. Normal adrenal glands can be visualized up to 75% of patient using I-123 MIBG, not I-131. Free iodine in the bloodstream may cause some uptake in the digestive system and thyroid if not blocked. No skeletal uptake should be seen. In children, uptake in brown fat can be prominently seen. Now, pathological uptake, I-123 or 131 uptake in adrenal glands considered normal if mild. So we compare it with the liver, or if it is symmetrical, and when the glands are not enlarged on the CT scan. High intensity uptake, more intense in the liver, or inhomogeneous, incongruent, heterogeneous uptake is abnormal with a concordant enlarged adrenal gland. Extraadrenal sites of uptake that cannot be explained by normal physiological distribution are considered abnormal and pathologic. Indications of MIBG therapy. I'm just going into the therapy just for a small while. Tumors showing adequate uptake and retention of MIBG on the pre-therapy scan. Inoperable pheochromocytoma, inoperable paraganglioma, carcinoma tumor, stage 3 or 4 neuroblastoma. These are a few indications for the therapy part. Now, once again, going back to the scanning part. Patient preparation, very important. Why? Free I-131, free iodine 131, which is the only thing which is used in India. We don't have I-123, which is dissociated from I-131 MIBG, may accumulate in thyroid gland and cause hypothyroidism by irradiation. To inhibit the accumulation of free I-131 in thyroid gland, thyroid blockage with stable iodine is important. In India, we don't have potassium iodide and all those things. I mean, we do have, but they are not available. We give Lugol's solution 1 to 3 days before and 7 to 14 days after I-131 MIBG in administration. This is basically 1 to 2 drops per kg to maximum 40 drops. So if it is 40 drops, give 20 drops twice daily. It is available in near AIMS. There is a place known as Nath Brothers in Ansari Nagar. We ask the patients to go there and buy Lugol's iodine, 1% solution. Drugs for thyroid blockade, we have already seen potassium iodide, iodide, and perchlorate. Other drugs which need to be stopped are also important. There's a plethora of drugs, antiarrhythmics, alpha beta blockers, adrenergic neuron blockers, calcium channel blockers, even before imaging and therapy, both inotropic sympathomimetics, vasoconstrictor sympathomimetics, beta 2 stimulants, systemic and local decongestant, cough and cold preparation, antipsychotics, opioid analgesics, tricyclic, antidepressants, and CNS stimulants. Now, most of the children are not having any of these. So fortunately, we are safe that most of the children will not have any of these. Why are we stopping all these things? What is the relation with MIBG? There are 5 mechanisms which are said: inhibition of sodium dependent uptake system, transport interference, depletion of these granules, calcium mediated, and other possible causes. So there are a number of causes. I'm not going to detail because of lack of time. So these also need to be stopped. Then administration, it is given slow IV infusion. Generally we give 45 minutes to 1 hour. Monitoring of vitals is important. Most frequent recommended is catecholaminergic tumors. Short-acting beta blockers may be given in emergency use if there is a catecholamine surge during or immediately after I-131 MIBG administration. In practice, unstable hypertension, if it is there, it can be managed by reducing or temporarily stopping the infusion. Now, this is basically, once we give MIBG, urinary MIBG excretion is important. So these children who are given MIBG for scanning or for therapy, both have to observe rigorous hygiene to avoid contaminating the person in the same toilet facility. If they are going into a home and they don't have this separate toilet facility, the children should be they should be warned to avoid soiling underclothes or areas under the toilet bowls for 1 week. Soiled clothing should be washed separately. A double toilet flush is recommended after urination. Incontinent patients, children who are really sick, need to be catheterized before the administration and should remain in place for 3 to 4 days. Now, when we give therapy, now I-131 therapy is also given in MIBG. Hematological monitoring is essential to anticipate significant myelosuppression and plan subsequent treatment cycle. So the main side effect is myelosuppression in case of therapy, not in case of imaging. So now we were initially talking of PET imaging. Now this MIBG is basically gamma imaging. Type of imaging which we do in gamma is whole body imaging, planar, anterior posterior views. SPECT stands for single photon emission, computed tomography, and hybrid SPECT CT. The major disadvantage of planar imaging is lack of anatomical information. So we do a SPECT CT imaging to give a much better hybrid image, and we can anatomically localize the lesions, areas of doubt seen in the planar images. This is just an image of the gamma camera. Here we can see these are the 2 heads of the gamma camera. This is not a dual head gamma camera. 2 heads of the gamma camera. This is the CT scanner. There's CT gantry. So this is in this camera we can do a SPECT CT imaging, which is a type of a gamma imaging, but we can get a co-registered image, and we can get a exact anatomical localization just like PET CT, but it is not as good as PET CT. Basically, these CT scanners of gamma cameras are having like 2 slice or 4 slice CT scanners, so they don't, and we are doing mostly a non-contrast enhanced CT for localization, low dose CT, what we say. So this is just for localization and not really a diagnostic CT. This is a case of pheochromocytoma, basically with poorly controlled hypertension and elevated catecholamines. Distribution is normal except focal markedly increased uptake in the left adrenal. Here we can see a left adrenal consistent with the pheochromocytoma. This is a case of a neuroblastoma, uptake in the primary retroperitoneal tumor, as well as you can see all these inhomogeneous uptake suggestive of a marrow metastasis in the cranial vault, skull base, sternum, ribs, pelvis, tibia. So this case is basically a metastatic disease in the bone. A 6-year-old child affected with neuroblastoma. Now where does PET comes? PET comes in MIBG negative cases. You don't see anything here in the MIBG. This is just you can see some cold area, but nothing you can see. But when we do a PET, we are very nicely able to see the MIBG negative tumor which is hot on PET. So once they de-differentiate, once they go into a poorly differentiated this thing, it is very nicely caught on PET. Summary for neuroblastoma: there is strong evidence that I-123 MIBG scintigraphy. We don't do I-123, we do I-131. Planar inspect remains the method of choice for non-invasive staging of children with neuroblastoma. All equivocal cases on CT can be resolved by SPECT CT due to high specificity of MIBG. First SPECT CT should be performed. If negative, contrast enhanced CT could be discarded. Single positive equivocal MIBG foci without concordant morphological changes may need histopathological confirmation. Now, few other traces are also there in this arena. F-DOPA PET CT is not superior to MIBG. However, DOPA PET need to be is actually the most promising tracer with potential to replace MIBG scintigraphy in the diagnostic workup of neuroblastoma in the future. This was few years back. Now there's another thing which has come, which is basically the DOTA-TATE or DOTA-TOC PET CT. They are more promising than even DOPA. FDG PET is indicated for discrepant findings in function and morphological imaging. So basically you have MIBG negative cases, you have discrepant findings, you can do FDG PET. Multi-modality imaging approach with MIBG, MRI, MIBG CT or PET CT has potential to increase the diagnostic sensitivity and specificity as compared to the single modalities. So the number of traces are there. Still the workhorse here remains the I-131 MIBG. Then you have the FDG PET CT, you have F-DOPA, you have DOTA-TATE, you have somatostatin receptors. A lot of things are there, but still the iodinated MIBG still holds ground. So with this, I will end my presentation because we are already, I think, short of time, and I would like to thank the audience for a passionate listening, and we can take few questions or any comments or additions here.